Hi, everyone. I'm Annie Jaworska, Outreach Manager for Rogers, and we're glad you could join us today for our Facebook Live Q&A. Today, in honor of PTSD Awareness Month, we will learn more about trauma, how it connects to post-traumatic stress disorder, PTSD symptoms, and treatment for the disorder. We are joined today by Rogers's Dr. Chad Waterneck and Jennifer Para-Nelson, who will help us explore these topics. Feel free to comment with questions, and we'll do our best to answer them at the end. Dr. Waterneck and Jennifer, thank you so much for being here today.
Thank you for having us.
Yeah, thank you for having us. I'm really happy to be speaking with everyone today.
And I think this is a pretty important topic. If I just throw out a few research figures here, we know that over half of the people over the course of their life will experience a traumatic event, which is one of the symptoms of post-traumatic stress disorder. And about a quarter of them will go on to develop the full condition. And since many people end up suffering in silence because talking about these events is incredibly difficult for many people, I'd like us to get this information out there so people know help's available.
Right. And just to connect with that too, I'd like to start by saying PTSD is not something that can be treated without a trained professional. Often people feel like it's a weakness or a character flaw that they cannot handle or get over what happened to them in their lives. It's a cultural misconception that we should pick ourselves up by our bootstraps and not ask for help. And it's also a misconception that we don't prioritize our mental health. So the truth is, to feel unsafe in our own bodies and our minds is not our fault. So trauma is an extraordinary circumstance and it's beyond normal comprehension. And that's why our bodies and minds are experiencing such constant distress. Therefore, it's imperative that we seek support, and we seek the right support from those who know how to treat PTSD.
Wonderful, and so grateful again to have both of you here. And I agree, this is a very important topic to talk about. So glad that we can have the opportunity to dive a little bit deeper. So let's get started with some questions. For those viewing today, remember, if you have any additional questions for our panelists, please feel free to comment with those, and we'll do our best to answer them at the end. So our first question that we have here for Dr. Waterneck, could you explain what trauma is and how does it relate to post-traumatic stress disorder?
Sure. So trauma is an event that happens to us or in our presence or that we learn about that's incredibly distressing. It's also one of the symptoms of post-traumatic stress disorder. Now, the trauma itself is usually something, but not always, but most of the time does elicit some sort of strong emotional response where someone feels afraid, helpless, or even in horror of what's going on around them or to them. We'll talk a little bit more about what those things could be, but it's really important to capture that. Many times people will interpret the event to be life-threatening, either to themselves or to the other people that it might be happening to. And as I said, it's just one of the 5 main symptoms of PTSD. The other symptoms include things like re-experiencing, meaning you will most commonly have nightmares or what we refer to as flashbacks, where you feel as though the event is reoccurring in the moment, even though you might not even be in the same surrounding or have the same people around you that were potentially a perpetrator or someone that was there during the trauma. It isn't always that obvious in terms of seeing things in a flashback or a nightmare. Sometimes it's just your body's limbic system activates and basically just says, I feel very afraid. I am under threat in this very moment. I'm not even sure why. But that's another example of re-experiencing. On the other extreme end, sometimes people don't remember what happened to them as well, which of course is much harder to study, but we know it's possible. I already mentioned this, that a lot of people suffer in silence because the third symptom is actually avoiding things that remind them of traumatic events. And that extends definitely to things in your external environment that remind you of the traumatic event. So if someone got in a serious car accident, they might avoid driving their car altogether, or if it was on the highway or while they're going fast, they might avoid those things. But they're also going to avoid internal reminders of the trauma as well. That usually means things like seeing images, thinking about their safety, but also their emotional experience. So emotional experiences tend to be seen as potentially something that could be threatening, because as your emotional system activates, people start wondering, oh my gosh, is this an activation? Even if it could be in response to something positive, that means I need to be aware and alert. The last two symptom areas are really a collection of things that have to do with changes to the way you think, the way you experience or interpret emotions, or physiological changes in your body and reactions to anxiety. So in terms of changing how you think, you often will take more responsibility for things that you needed to, including the traumatic event happening. Many people find themselves thinking they're fully to blame for it. Many people find themselves not wanting to trust other people and assuming that more danger is going to happen. And a lot of folks will begin to doubt having faith in their own thoughts and emotions and ability to trust themselves as well. In terms of change in emotions, I think the most common thing that happens with people is that, they become so emotionally reactive to anything that could be like fear that they want to, find a switch in their brain that says anxiety on and off and turn it off. And some people are successful in finding that, but what ends up happening is that switch isn't just for anxiety, it's for emotional experience overall. And they end up feeling quite numb because they don't want to be emotionally activated at all. Um, there are some people that have somewhat of a traumatic response, and their emotions might kind of come out more than one might think they should if they didn't know they had trauma, where they might look, some people say, they look dysregulated or they look too emotional. And it could be anger or frustration. Shame is a pretty common experience as well. But there's not just one size fits all for the change in emotional experience. I also mentioned some changes in how the body responds to anxiety, since your body is likely going to be at higher stress levels throughout the day because you are what we refer to as hypervigilant. You're always looking for where the danger could come from and maybe where the safety or exits are in each situation. Your body's releasing more cortisol. This is increasing your stress response. And then when you try to go to sleep, your body isn't calm enough to go to sleep, and it's very disruptive. And of course, if you have nightmares, it's hard to get to sleep as well. So people are on edge. They can look and act quite irritable. And that's just some of the symptoms that could be part of PTSD.
Thank you so much for that, Dr. Waterneck. PTSD, based off of what you're saying, there's a lot to it. The emotional response, there's a physical response, but also folks experience process trauma in different ways. So it may vary from individual to individual. Jennifer, what type of trauma can cause PTSD?
So technically, a traumatic event is something that is experienced or witnessed and involves actual or perceived threat to life or physical integrity. Some examples could be disasters, sexual assault, physical assault, witnessing a shooting. Combat is one, neglect, especially in childhood, or any type of accident. And like Dr. Waterneck was saying, you respond to these events with fear, horror, and helplessness, and often extreme powerlessness. And what he was saying before too, statistically, 50 to 60% of people experience at least one trauma in their life, but only about 5 to 10% go on to develop PTSD symptoms at some point. There are acute traumas, which are single incident traumas. So like a car accident or maybe a natural disaster. There are chronic traumas, that's from repeated or prolonged violence or abuse. There's also complex traumas from exposure to multiple and different types of traumatic events in your life. There's this assessment called the Adverse Childhood Experience Scale, the ACE, which describes possible stressful or difficult experiences in childhood that might predict whether PTSD or other traumatic trauma-related disorders may develop in your lifetime. But trauma is very subjective. So for instance, two people can be in a car accident and have very different experiences. One may walk away and have very little impact on their life. Maybe they do have, some intense emotional experiences and maybe they refrain from being in a car for a little bit, but eventually their life returns to normal. Where another person can be in a similar car accident and have an intense reaction to it, right? And they no longer feel comfortable driving. They might have nightmares about the event. So two people can respond very differently to the same type of trauma. I think oftentimes people feel guilty or shame about how they've reacted to a trauma. Like, oh, how can this person, walk away and be okay, but I'm having, such an extreme reaction to it. And that's just how PTSD works. And support around a person after a traumatic event is very important and can predict too sometimes whether people go on to develop PTSD. If a person is in a traumatic circumstance and has great support, they might not suffer those long-standing consequences. But if a person has very little to no support, they may be in a position where PTSD symptoms develop because they cannot adequately process their trauma. And as I said earlier, trauma isn't something that is meant to be dealt with, or I'm sorry, PTSD is not something that's always meant to be dealt with and processed adequately by themselves. And I do want to say a little bit about community-based or collective trauma, as we're in a time where that is something that we all feel maybe susceptible to with the events that happen around us. So just to say, community can mean several things. It can mean people who share a geographical location, a congregation, a club member, any collection of people that share a similar interest or a similar location or have investments in something very similar. So community trauma or collective trauma refers to psychological reactions to a traumatic event that affect an entire society. It may happen to a few people relative to the size of the community, but the impact is on the collective memory within a community. And it may feel like it shatters the basic fabric of that community. So it's different from an individual memory because it persists beyond the lives of the direct survivors of the event. And it's remembered by a group far removed from the traumatic event, even in time and space. And subsequent generations are impacted, many of who've never witnessed the actual event. They may remember the event, they may remember it differently. The memory might take on a different shape or form from generation to generation. It might even be more psychologically stressful for the second or third generation as they grow up knowing this fear and disconnection from the community that once was a unified community. But on the other hand, there can be this relationship with collective trauma and the construction of meaning. Viktor Frankl, who's a Holocaust survivor, has stated in his book, Man's Search for Meaning, that trauma is destructive, but meaning is often unexpectedly found in calamity. And it can aid in the creation of a national narrative, a sense of identity, and overhaul possible systems that led to the trauma in the first place.
Thank you, Jennifer, for all of that great information and all of those details. It sounds like to me trauma is it's very complicated, and there's many different layers to trauma. And the goal is to really kind of understand and dive deep and understand exactly what is going on with the specific individual who experienced trauma, to really understand what happened and how to help that person and support them through it. I know we talked about this a little bit in the beginning, but Can you talk a little bit more about the common and not so common signs and symptoms of PTSD?
Sure. And just a reminder too that the diagnosis of PTSD requires a discussion with a trained professional. Many people experience these symptoms immediately after trauma, but do feel better, and the symptoms do go away within about 3 months. Others may recover more slowly or not at all with the help or without the help of a trained professional. So Dr. Wedderneck did a nice job of an overview. I'm going to go into a little bit more detail about some of the categories for the trauma symptoms or PTSD symptoms. And like he pointed out, there are two main categories: re-experiencing of the trauma and then also avoidance of things that remind you of the trauma. And the first one being the re-experiencing of the trauma with those intrusive, unwanted memories, flashbacks, nightmares, intrusive thoughts, things like that. So just to reiterate, an intrusive thought would be like a vivid movie playing in your mind, recapping the trauma. And then a flashback would be like you're back in the trauma and in that movie in your mind. So it's a real different experience, and you kind of lose sight of the present moment. And then avoidance, and this means that you're staying away from anything that reminds you of the trauma event or details from the trauma event, certain places, people, conversations, activities, situations, objects that remind you of the trauma event, and even our own thoughts. We might want to keep ourselves very, very distracted in order to not experience any of those internal stressors. People may rearrange their whole lives to avoid the distress, feelings, or memories that are associated with the event. They may stop talking to family members. They may move to a different location. They may drive miles out of the way in order to avoid maybe a location that reminded them of the trauma. Cognitive and mood symptoms. You may have trouble recalling events. You might have negative thoughts about yourself or the world. I think this is a really big one too, because oftentimes trauma survivors feel like they're to blame for what happened, right? And they may have these beliefs that they're unlovable, or the world is dangerous, or you can't trust anyone. You may feel distant or detached from others. You might find it difficult to maintain relationships, or you might find yourself sabotaging relationships, believing that you're not good enough, or this person may not really feel the way they're saying they feel about you. Being intimate with a partner may be difficult or even non-existent. It might be really difficult for you to feel any positive emotions. You might not even remember the last time you felt a positive emotion since the trauma occurred. You might feel more impulsive, maybe more oppositional. People might think you're acting maybe extreme in their eyes. You might engage in high-risk behaviors like self-harm or substance use or unsafe sexual practices. We talked about those arousal symptoms too, like hypervigilance, feeling on guard, maybe needing to always sit by an exit, maybe needing to always have an exit plan, possibly really hating when people are behind you, always wanting to make sure that you feel safe, even though the situation may be very safe. You might have an increased startle response, right? So you might be jumpy, jittery, or shaky. Things that might not normally startle someone will startle you, and maybe you feel startled all the time. Difficulty sleeping, difficulty concentrating, extreme irritability or outbursts of anger. And you might also feel the opposite. I mean, there's such a variety of symptoms. You might freeze up. You might feel like a deer in headlights, and you might feel very numb. And then there's a part of guilt and shame where you, like I said before, you may feel like you blame yourself for what happened, and you might be saying to yourself, I should have known better, or I should have fought harder, or I should have left, when reflecting upon the trauma. And it's very common for survivors to blame themselves for what happened and to carry that shame with them throughout their lives, especially if the trauma has occurred in childhood. Oftentimes we're not having that support to tell us that it's not our fault. So we have to sort of create that narrative and find some control in the situation. And maybe the only way to do that is really to blame ourselves and try to figure out how to not do those things again so it doesn't happen again, which will lead to some of that avoidance and some of those other symptoms that we've been talking about. And this also really blurs our self-image, right? The way we feel about ourselves. And we might feel like we're immoral.
Looks like we have a little glitch here. And I'm wondering if I could pick up. Jen realizes that she's not on anymore. She was doing a wonderful job of really outlining and fleshing out all the symptoms that can occur. And there's a few things I wanted to pick up on, and I know you have more questions for us, Annie. And that would be that when people are considering, our mind has this tendency of trying to solve problems that are unsolved. The reason why a traumatic event happens is often unknown. It can just be simply an accident, but it could be an action of someone else that you know or don't know that does something terrible toward you or threatens you with that. And what people tend to do is they try to think about, how can I prevent this from happening in the future? How could I have been safer in that moment? What were the signs? And so they only think about the things that they could do differently. And that's going to lead them to actually conclude that since there are things I could have done differently, I'm actually responsible for what happened. And this is really incredible that it also occurs with events that happen when people are children or adolescents, where they like physically could not escape a situation, maybe an abusive household or an abusive person in their life. But then as they grow older, they realize they have more options, and they start conferring those potential options on their younger self and saying, I should have told someone that 18-year-old was physically assaulting me when I was 5, even though they threatened me. And there's so many situations where it's hard for loved ones and sometimes the trauma survivors themselves to understand, why do they blame themselves when there's so much evidence that it's not their fault. I think another thing that's important, going back to what Jennifer was saying, was that we have to understand that it's the perception of threat, and that's the most important thing. This is touching on what she was saying about meaning. For some people, they could escape from a car accident, for example, and really be very emotionally activated, but they might actually somehow be thankful. They might say, oh my gosh, I can't believe we survived, and I'm so grateful. And that's how they carry forward, for the next couple of days of their life. They're still, like emotionally activated by this, but they're able to reframe it in some other way. The other people might not be able to do that. I want to give an example of how perception might play a role as well, in that even if you find out later on that you weren't actually in the danger you thought you were in, you could still develop PTSD. So one of the earliest people I worked with was a bank teller, and she was robbed at gunpoint, or so she thought, by someone who was apprehended immediately after leaving the setting. And the police ended up being able to find out that the person did not have a weapon. The whole thing was on camera, and the person just had their hand in a jacket and was pointing at them. It didn't matter. The perception was my life was in danger. And next thing you know, a lot of symptoms of PTSD were occurring after the fact. And she ended up coming in about 9 months later because she was unable to go back to work as a result. So someone telling you, hey, well, you're alive, or it didn't happen, you should be thankful. It's hard to talk to your limbic system and say, don't activate and try to do fight, flight, or freeze. Just listen to reason here. That's just not the way our brains work.
I think that is a very important piece that you mentioned, Dr. Waterneck and Jennifer, this perception piece, that you may have two people experiencing a trauma, but each person will experience that differently. And just being mindful of just not having any judgment with the differences in how they experience that trauma, and that it looks different. This leads us to our next question really nicely. Are there any risk factors for diverse populations and important aspects of identities that may develop PTSD over others?
Mhm. Yes, I mean, the short answer is yes, and there's a growing body of literature that supports this. So I'll speak to some, but not all of the information out there because it's a pretty large body of literature. Um, we know that non-white folks, for example, if we just looked at the construct of race, are much more likely to develop PTSD. And there's reasons for that, but we'll see prevalence of PTSD in both the United States and Canada higher for non-whites or white people that also are ethnically considered Latinx or Hispanic. These rates are also higher in Native American populations, in Black populations, and even in Asian populations. And there's rationales for this as well. There's a couple of theories floating around there that seem to have a lot of validity to them. One of them is the sensitization hypothesis, and that is that the more traumas you experience, the more it's going to take a toll on you. So while some people are able to stay resilient up to a certain point, at some point you might reach a threshold or breaking point where you end up developing more symptoms of PTSD and maybe even the disorder itself. We do know that there seems to be more challenges and experiences sometimes based on their identity, whether that's based on race or sexual orientation or education or ability, disability, many other, gender identity, that some people, because of their identity, end up experiencing more negative events directed toward them. And many of us can point out that if someone was subject to something that was racist, sexist, something else that we might call it, that was racist, that was sexist, that was, well, inappropriate and uncalled for, which is what all of those things are. There's almost always a history of implied threat and pointing out a power differential in those situations. So someone doesn't have to say, I'm going to harm you. And in order for that to be a trauma, they could say something like, you don't belong here. You're not welcome here. And that can carry certain overtones that tell the person, knowing based on the history of things that have happened, not just in our country, but definitely have happened in our country, that could mean it could be a life-threatening outcome. So we know that more people are often under stress and experience more distressors if they have non-majority part of their identities, which it's not their fault. We also know that sometimes people might not have the same levels of support as well to deal with those stressors. So that's a pretty big combination. Now, there's some other really fascinating research here that shows that there are likely other nature and nurture aspects to the development of trauma, which might leave some people more susceptible than others. One of them, and I'll just paraphrase the study that came out in the journal Nature in the last 10 years, looked at an animal model where they had some animals respond to a specific type of stimuli, and they experienced an adverse consequence from it, like receiving a shock, whereas another group did not. And then they separated all these animals. The animals reproduced, and all of them were separated from their parents, so there wasn't like a mimicking effect or modeling effect from them. And when the group that was descended from the group that received the shock in the presence of what ended up being the smell of a rose, when they felt that, they had an intense fear response. So we know that it is possible, sort of like what Jennifer was already referring to as kind of like this collective learning, that there could be some transmission through one's genes to make people more susceptible. And then when you think about if some groups of people may have been subjected to more difficult aspects, that they are also going to be more predisposed to recognize things as threatening to them. There's another aspect of nurture that's really important as well, and that is modeling other people's responses. We often learn a lot of thoughts we have and consequences, and also emotions and appropriateness of emotions based on what we see around us. For many of us, that's with parents or the caretakers or people that raised us. There are studies that show that if people like an adult who's raising a child experiences a traumatic event and has PTSD after the child is born, that their child will start adapting and doing behaviors and scoring much higher on symptoms of PTSD, even though they did not directly experience the traumatic event, and that the parent did not experience trauma prior to the child being born, meaning there wasn't that genetic transmission. There's even some really kind of highly detailed studies that look at whether or not gene alleles change as a result of being exposed to trauma or exposed to other people that are responding in ways that show they have PTSD symptoms. And this area of study is called epigenetics. And what we're learning is that the genes that you have can be altered while you're alive, and that some of the genes that we're looking at as markers or predictors of showing PTSD are altered after the person is born due to the experiences around them. So these are pretty powerful things that we're dealing with here. Jennifer already said that sometimes people, when they're given feedback by loved ones, the loved ones, of course, they might be meaning you well, but they might think like, can you get over this? Are you able to deal with this and move through it? Or I don't understand why this still bothers you. It happened a year ago. It's because it's actually affected people at the biological level.
I see. And wonderful, so much information. And we have so many great questions coming through too. So we're going to just answer one more question before we get to the questions that are coming in. And very important piece to our discussion today. How can PTSD be treated?
Yes. And yeah, I'll take that question unless Jennifer ends up joining us again. Jennifer already said something that's very important. In order to be diagnosed and treated, you really should work with someone that is a mental health professional and has had specific training to deal with trauma and PTSD. There are many people that can be helpful to you, but to actually directly target the symptoms does require some specific training. So one of the first things I tell people to do is if you need a referral, you might need to go to your primary care physician, since that's kind of like the most common thing to do. But you could call into a place that you find either on Psychology Today, or maybe you call a place like where we work out, Rogers Behavioral Health, and you do a screening with them, and they will assess what your symptoms are and help direct you to a program. And sometimes that will be directing you to a program outside of our system because maybe that's the right thing for you. But it's important for the public to know that there are, just like in medical science, there are evidence-based therapies that have been researched and have been approved by important organizations like the American Psychological Association, Substance Abuse and Mental Health of America Association, the Veterans Association. And they've consistently said that 2 to 3 therapies have been the most widely researched and are accepted as kind of like the frontline thing that you should probably try to do. So I'll mention their names here. And the one that we do primarily at our hospital is something called prolonged exposure. That happens to be the therapy of the 3 that I'm going to bring up that has basically the most research trials on it, the widest amount of people in those research trials. It's been well tested in adolescents as well as adults. And I just published a paper on this. We had the most amount of diversity as well, where it seems to be that it's been tried on a wide variety of people in regard to their identities. Cognitive processing therapy has been the next most tested therapy. And it also demonstrates a pretty wide array of, varieties of people that have come into it based on sex, gender, race, and ethnicity. And then another therapy that should be strongly considered as well is eye movement desensitization and reprocessing. And that one has a little bit less data on it. But, if you're asking me, which one do I go to? I will tell you, go to any one of those 3. All of them can work and can be a benefit for you. And if one of those doesn't work for you for whatever reason, and sometimes it's the match between you and the provider, find one of the other 2 and start there. There are many other therapies out there. Most of them have very little research to them. They could be very helpful, But it's sort of like saying you're going to try a medication for something that's going to treat a physical ailment, and we've tested 3 of them really well, and a couple of them might work. Try the stuff that we know works first.
Wonderful. So the 3 most evidence-based treatments for PTSD, as you mentioned, Dr. Waternick, prolonged exposure, cognitive processing therapy, and EMDR for short.
Yep.
Wonderful. Well, thank you both so much for your insights and thoughts. So let's check to see what we have here for questions. So our first question here, can childhood trauma bring on bipolar, borderline personality, or schizophrenia? Trauma was at ages 5 to 8, and behavioral issues started 10 years later as memories resurfaced of that trauma.
Jennifer, do you want me to take the first shot at it, or would you like to?
I'll just answer a little bit of that. I mean, I know that there, especially in childhood trauma, there's something called complex trauma, which can bring on symptoms that are very similar to some of those symptoms that of the diagnoses that you mentioned, like bipolar and borderline personality disorder. I'm not quite sure about schizophrenia, but I know that we've had a lot of people come into our programs already having those diagnoses. So there is some overlap, and they are doing research now talking about borderline personality disorder and complex trauma. And maybe there is some crossover in an intersection where they kind of come together in a certain way. When you grow up, oftentimes in a household where there might be some abuse, or there are other traumas that are happening, oftentimes there might be some other corresponding mental health issues that maybe are predisposed within family, or that are alongside of some of the PTSD as well. So, I mean, it's really hard to say based on a question, but there's definitely overlap, and we've definitely seen those overlapping diagnoses within the trauma programs here.
I think along with the symptom overlap, we know that some of these disorders that you mentioned, like schizophrenia and bipolar, they have a little bit better well-documented like genetic transmission, increasing the likelihood that someone's descendants will have this. It doesn't mean that that's why they're going to have it for sure. They're just more predisposed to have it. But what trauma often does is it seems to exacerbate other things that are there. So a lot of people, will talk about trauma as being kind of like a gateway to all sorts of mental health issues. Well, that's possible, but many people can develop issues prior to trauma, or maybe they have some co-occurring. Trauma seems to interweave with them a bit. And in trying to stay safe and be in control of oneself, it might lead to other types of behaviors that are categorized by other disorders. And in that sense, it kind of gets woven together. In order to feel safer, I do these other things. Like maybe I isolate a lot, and then I develop, a stronger sense of depression, and I actually become depressed. With schizophrenia, there's this idea that it's not that everyone who, has a parent, relative, or something like that with schizophrenia is going to become schizophrenic, but the more stress someone is under, the more likelihood, or maybe the earlier that some of the symptoms might show up, or the onset might occur earlier. And of course, we just don't know if they didn't experience the trauma, would they have developed those symptoms? So there's a lot of stuff in research that requires some pretty intense longitudinal studies where we can't get that kind of like causal inference there, that's why it's caused. But I think what we see is it does exacerbate things that are there, sometimes bringing things from subclinical levels to clinical levels, or clinical levels to even more severe clinical levels in the other conditions.
Thank you. Our second question here, we talked about the evidence-based practices, but what else would you recommend patients with PTSD look for in a provider?
Oh, yes. This might be a little self-serving here. We may have a blog on this that I wrote on our website at Rogers, but the key is, like, you're looking for someone that's a specialist. So it's very common for people, if they know what Psychology Today is, to go on that particular website, look up different providers on that website. And sometimes it could be, I like their picture, I like their theme, I like the way they describe the way they do therapy. But you should also be willing to ask them questions. I think a lot of people think that, it's like going into, this is not as simple as this, but going in to get a haircut, right? If you got a bad haircut from someone, you're not going to go back to that person over and over again. But I think people have this idea in therapy that, well, once I go to someone, I'm kind of committed to them. And now I told them some of my stuff, and now I have to keep going back. And that's really not true. If you don't feel as though the person is someone that you mesh with for whatever reason, you could consider someone else. You could consider another referral. But I would advise people to ask someone that they're looking into as a provider a couple of specific questions. One is, how did you get your training in working with trauma? How do you measure or know when someone gets better? There's lots of ways, clinical interviews or even self-report type measures that people can give that can track symptom progress and gains in life as well. I'd like to know, how are they going to be able to tell me I'm getting better, not just take their word for it or take my word for it, because they're the expert, right? What percentage of your current clients that you see do you see specifically for trauma or PTSD? This gives you a little bit of idea that when you see someone who looks friendly and you call them and they say they have 20 different specialties, well, what percentage of their practice is actually showing that they specialize in this area? So maybe they went to a training. Maybe they are actually fairly good at it, but I think you get even better by really being specialized. This is I don't want you to worry about the clinicians, but this is really a high level investment for clinicians that specialize in this area. So a big shout out for them as well. They have to be able to sit with some really strong emotions and feelings. And, we're already a caring group of folks to begin with, that we have to practice this so that we still maintain our appropriate boundaries while being able to assist and talk through these details that were likely life-threatening, likely some of the most sensitive things that ever happened to them. So screen your providers if you can, and decide what you need from them in the first meeting. And if you don't feel like they're going to give you what you need, you could consider stating what your need is. That's a huge thing to ask someone to do, but I at least want you to consider that you should be working with your provider. It's just like going to a medical doctor for a checkup, and they're going to ask you what's wrong with you. And if they don't ask you specifically what's wrong with you, you should bring that up. Oh, you didn't ask me whether or not my toe still hurts from last time, but it still hurts, so be willing to kind of state your needs too, if you can.
And just to piggyback off of that too a little bit is, it can be really anxiety provoking and may also activate some of your PTSD symptoms to go into those first conversations with a provider. So preparing beforehand, writing things down, maybe writing your symptoms down, writing what you're avoiding down, what your needs are, the things that, you used to be able to do and now are unable to do. And just know that in those first couple of sessions, you do not have to share your entire trauma. You can get to know someone and get to feel safe and secure with someone before you, share the details of that trauma.
Wonderful, thank you. Another question here. I'm in therapy for trauma in childhood. Do you think we can ever get over trauma, like let's say sexual abuse?
Short
Absolutely.
answer is yes.
Yeah.
Yes.
I think Dr. Wedderneck and I have worked with lots of patients, and to be honest with you, that is probably the most frequent type of trauma that we see at this level of care in partial hospitalization programming and intensive outpatient programming is the childhood sexual abuse and the chronic sexual abuse as well. And it's incredible. And this person who asked this question is an incredible person to be able to have, become an adult with everything they went through. And the fact that they're able to watch this and answer and ask this question is incredible. So yes, I mean, they probably are, have more fortitude than they give themselves credit for. And we just help to parlay that into healing, right? We want to go from having PTSD and having the trauma symptoms dictate your behavior to a history of trauma where, yes, you've had experienced this trauma and you're always going to have it in your mind, but it's not going to then dictate your life anymore. And that's very possible.
Mhm.
Thank you. How do you deal with it when you already have severe oops, sorry, um, CPTSD, and you keep getting traumatized over and over again by the same and new traumas?
Yeah, and that's so that acronym is like complex trauma, and we didn't really talk a lot about that right now, even though I'd say most of the people in our programs actually would fall under the diagnosis of complex trauma. And there's a little, it's not really a controversy, but the guidelines that most American mental health providers follow are from the Diagnostic Statistical Manual for DSM-5, or the fifth version of our like how to diagnose things. Complex PTSD wasn't put in as an official diagnosis, but it is in most of the other worldwide diagnostic definitions. So we often still refer to it as complex PTSD here. And just to add in on how it's different from PTSD, it's everything PTSD could be, but it's likely, almost has to by definition, start off in childhood and adolescence and be repeated. And it affects people's developmental growth. So there's a lot of things that people learn about life and autonomy and emotional experience that gets interrupted or altered during those times and repeated traumas, where it results not only in the symptoms of PTSD, but also difficulty in regulating one's affect. I don't look at that as necessarily like there's something wrong with the person. It's just their trauma response could be their emotions come out more often and stronger than what other people might in that situation who hadn't been traumatized. There's also a lot of difficulties in interpersonal relationships as well. Some of these folks, and this could be a little triggering to talk about, but some of these folks may have been tricked or groomed by someone to think something was okay that really wasn't okay. And it's not their fault it happened, but that becomes very confusing to think about how do I develop now a safe relationship with someone when, an adult that I trusted told me certain things were okay to do. So with this particular person here, this isn't easy to do, and it's possible. One of the things that you need to do is try to make sure that you can reduce the amount of um, likelihood of traumatic events happening while you're in treatment. I know that's not easy to do. Sometimes people live in a situation where they don't have much control over their environment, or maybe they live in a part of town where, there's gunshots or more violence occurring. But reducing that as much as possible might be what they need. If they've already been going to outpatient therapy for a significant amount of time and there's not significant change, doesn't mean that your therapist isn't doing the right thing. It could mean that you need a higher dose or a change of settings. And that could mean finding a partial hospitalization program. Sometimes that's for trauma or post-traumatic stress disorder. Sometimes it would be for something that could help you learn a lot of good coping skills and psychological tools. There's a therapy called dialectical behavioral therapy that's now undergone some research trials for borderline personality disorder, but also a whole host of other conditions, including post-traumatic stress disorder or complex PTSD or post-traumatic stress disorder with borderline personality disorder. So finding a good base for skills, trying to be in a setting where you can have the most safety possible, and sometimes that is a residential setting is needed in order for you to be able to separate and then find a more of a safe landing point once you leave. But you often need a little bit more safety for your skills to work, and you might need a higher dose. So without knowing more detail, I think that's the place to start. And
Okay, we have so many great questions. Next question here is, if someone is diagnosed with PTSD times 4, how do you recommend treating it? Any certain medications? Some medications have severe side effects.
So, Jennifer and I will consider carefully how we respond to these things because
Mhm.
neither one of us is a medical provider, but we're both licensed mental health professionals. And what I can tell you is that there are some medications that have found to be helpful in reducing symptoms, although most of the time, either a combined approach of medication plus therapy is needed, and that therapy can be just as effective or more effective than medication alone. At the risk of going outside my scope, I will mention things like there are certain types of medications often classified as selective serotonin reuptake inhibitors that often target anxiety and depression that can reduce some of the symptoms of PTSD, but those things are not often designed specifically to target all of the symptoms of PTSD. There are a few medications, one of them being actually a blood pressure medication that seems to be quite effective in reducing nightmares. If you take it, and you go to bed at night, it seems to be able to help reduce the stress level enough so that your body isn't so full of cortisol and reacting and fighting off things and stressed out that you can get better sleep. Um, there are certain medications that people are prescribed to try to augment something like an SSRI. Sometimes those are antipsychotics, and you're not being prescribed them because they think you're psychotic, but because it can sometimes augment the treatment. I mean, obviously, working close with a medical professional is the ideal thing, but I want to make sure we address the first part of what the question was, and that was PTSD times four. So I interpret that to mean you've had at least four or more specific or different types of traumatic events. And that's actually the norm for people that come to our levels of care at Rogers, where it's very uncommon that someone has one traumatic event. I mean, that can be incredibly difficult to deal with too. But those folks are more likely to be able to be helped through some of the once or twice a week outpatient modalities, but not all. And we end up working with one of the traumatic events. And as we work with that one traumatic event and you notice that your symptoms decrease from that and you develop more autonomy and power and control in your life, it does help reduce some of the severity from the other areas. And then it normally allows you to deal with those other areas more directly in lower levels of care. So someone might come into our residential program, work on one or two specific traumas, and then they might step down to our partial program, or they might go to outpatient, and then they continue that work but also work on another trauma or two. Now, if you're out there and you've had 50, 100, or countless traumas, you don't have to talk about and work on each one. We have found time and time again that if you work on, I don't know, I don't have a magic number for you, but the benefits you get from therapy will generalize to the other symptom areas. And then you will just talk about the ones you need to after that. So hope is not lost if you are someone that has had dozens or 100 or more traumatic events.
If someone does have PTSD and is an introvert, how would you recommend them to pursue therapy?
I would say that a lot of people with PTSD have a lot of introverted features. And I think it has a lot to do with the rapport of the therapist. Obviously, after finding that this therapist has the right credentials to treat trauma, finding, some things that you're comfortable with. Sometimes in the beginning, we talk about bringing, some safety objects, whether it's a blanket or something that makes them feel comfortable. But the trauma treatment, the PTSD treatment is a gradual process. So with that gradual process comes that slowness starting where you are. It really is dictated by what you're telling us, what your anxiety levels, and we try to be really considerate of what your anxiety levels are throughout this process. So finding someone who you feel like fits who you are, but also knowing that in certain trauma treatments, it is a very gradual process. So they will be able to build up that tolerance for sharing things and becoming more vulnerable in those sessions.
I might just add in too, like making the call is really difficult.
Yeah.
We talked about avoidance as one of the primary symptoms, which is why people don't recognize how widespread PTSD is. Talking about it means I think about what happened. That elicits those feelings of fear and helplessness. Nobody wants to feel powerless. So it's a good reason to avoid talking about it. If you do have someone that you trust, it could be making sure that, would that person be willing to take a phone call from you after you call a provider? Would they be willing to be around while you're doing it? And you best to know, would that be harder or would it be easier? But consider whether or not you can create some more safety around you, even as you're approaching engaging someone to talk about scheduling an appointment.
Absolutely. And it's reassuring to hear that, it's a gradual process, it's a slow process, and just being patient with the individual and working with them one step at a time. Our next question here, doesn't everyone have PTSD on some level?
Well, that's an interesting question, and I guess I would say that any way to rate people is on a continuum. Now, technically, saying you have PTSD or not, it's really categorical or dichotomous. You either meet the symptoms or you don't. But on a continuum, have we experienced traumatic events? That's in the eye of the beholder. Remember, your perception of what happens is what's most important. If you thought something bad could have happened, even though it didn't, and you later found out it couldn't have happened, like that example with the bank teller and the person not having a gun, it doesn't necessarily make anyone feel good. It's also important to note that PTSD actually got its own area in our diagnostic system where it's PTSD and related syndromes. And people can experience great changes in their life. Like, for example, losing someone unexpectedly. That amount of grief could be PTSD, or it could qualify and contribute to something that we call an adjustment disorder. Other things that are not as life threatening to you, but are really impactful, like a divorce, a loss of a job, a move away from supports. Maybe you move across the country and your whole lifestyle changes. Maybe all your kids leave the house if you had kids, and it's such a big life change that you could develop an adjustment disorder. So we would, and I'm not going to call that trauma light. It's still very impactful. It can lead to a lot of anxiety and depression, but there is a continuum that everyone could fall on for trauma itself. PTSD, though, technically, you have it or you don't.
What about trauma at birth, being premature and undergoing surgery at a day old?
Yeah, Jennifer, I don't know if you were about to say something or you want me
I
to
was
take
going to say, I think you should answer this,
Okay.
Dr. Woodman.
So, we have some difficulties in capturing all things that are traumatic. A lot of the ways in which we think about trauma are things that people experience, and then a lot of the way we talk about trauma has to do with the way we remember it and how it expresses itself. Now, our body can remember things that sometimes our brain doesn't remember, because someone that's a day old, someone that's even 4 years old might not have the cognitive abilities, the words to describe things, the awareness of internal bodily cues, recognize symptoms of anxiety or other emotions to actually really be able to tell us what happened to them and what that experience was like. So the really tough thing about our diagnostic system is something could have happened to us. It could, you could have it on video and documented. You could have the court records for it or the medical records for it. And what's important to know is, do you now act or look differently in your actions on other people that didn't go through those procedures? Do you, and what can we do about that? Most of our treatments for traumatic events do involve some level of being able to talk about the traumatic event. So I don't want to say you can't get help, but it might be you might need different types of therapy or different types of approaches related to those evidence-based trauma therapies. And what's most important is for you to be able to recognize, what type of life do you want to have, and to be able to communicate that to your mental health provider, and they can help you deal with things that help reduce your symptoms and help increase your ability to access the things you want in your life.
Thank you. So many wonderful questions, and thank you all to everyone who has submitted a question. for us. But that is all the time that we have today. And we just wanted to say thank you so much for joining us, and special thank you to Dr. Waterneck and Jennifer for your time. If we did not get to your question, or if you have additional questions about the topic that we discussed today, please feel free to direct message us on Facebook. And for more information on the mental health and addiction treatment Rogers provides, visit rogersbh.org. And for helpful resources like videos and blogs, visit rogersbh.org/resources. Thank you so much, everyone, again, and stay well.